I'm very happy to have the opportunity to talk with you. I have really two different subspecialty areas, movement disorders and clinical neurophysiology, and there is an important interface between the two. Clinical neurophysiology can be helpful in a number of situations, and I'm going to try to illustrate that today in my talk for you. So just sort of a general introduction first in terms of the purposes of a clinical neurophysiological evaluation. It can certainly help with the diagnosis in many circumstances. There are many types of patients where one can make the diagnosis clinically, but there are times when it is, hello? Everyone hearing all right? Yeah. There are times when it is, in fact, difficult, and I will be focusing on this particular aspect, but I just want to give the broad picture. It can also add precision to the classification of a particular disorder. One may know, for example, that it's myoclonus, but not what type of myoclonus. So physiology can be helpful there. Certainly, it can give an understanding of the pathophysiology in a deeper sense, and understanding the pathophysiology can lead to more rational therapy of the patient. And then another area is that of quantification that can be helpful in terms of monitoring therapy for a patient. And of course, lastly, clinical neurophysiology is a big research area in terms of understanding movement disorders and other aspects of human pathophysiology. So for the talk today, I thought I would focus on the diagnostic side. This is a big area, but I'm going to limit in order to be good in focus. And I'll talk about evaluation of involuntary movements, particularly myoclonus, and then secondarily, evaluation of tremor. These are perhaps the areas which are most useful, and therefore I'm going to focus on them. So let me discuss a case of a possible patient that one might see, both as a clinical movement disorder doctor and then perhaps getting a referral to the clinical neurophysiology laboratory. So this is a 35-year-old right-handed woman who has developed intermittent jerking of her left hand. The jerking occurs rarely at rest, but much more with action, which interferes with the skilled use of her hand. On neurologic examination, she's otherwise normal, and the MRI is normal. And the question then arises is, what is the nature of these jerking movements that she has in the hand? And this is a good indication for clinical neurophysiological testing. If one has an involuntary movement, there are ways of analyzing that to get some sort of sense about what it might be. Now, in terms of sort of twitching movement, one can think of a variety of movements that arise in the periphery, such as hemifacial spasm, fasciculations, and these are twitches that arise because of peripheral problems of various kinds. And in general, if one is confused about those, there are characteristic patterns on routine needle EMG that can be helpful. One can see myochymic discharges, neuromyotonic discharges, cramp discharges, a variety of things that will give away that this is a peripheral problem. I think in general one can make those diagnoses, but the needle EMG can help. I'm going to focus in on those of central origin, and in those circumstances, what's listed here are the physiological testing methods that one would use. Generally, I would start off with surface EMG activity that is associated with the movement. What does the EMG look like that is associated with the movement? And that actually, as we'll see, carries one pretty far along in terms of making the diagnosis. Second step would be to look for a possible EEG event associated with the movement. Third, to look for reflex production of the movement and the characteristics of that reflex.
Quick stop. Merkt euch Quick Stop, bitte. Quick Stop. So, Mark hat. Wir haben jetzt leider die ersten 2 Minuten verpasst.
Hello? Well, I was just hearing a variety of voices. I guess it's okay to carry on. Okay, so then the fourth method there listed under central origin as to look at evoke responses, and that would be in sort of special circumstances that we'll look at shortly. So the first issue then is, what does the EMG look like? And there are basically 3 different patterns of EMG. And the most important column is this one here, in which I give a sort of visual description of what these patterns look like. On the far left is a term that can be used, and on the right is some sort of analogy, but the critical EMG patterns are what is in the middle here. So the first pattern is a EMG that lasts more than 200 milliseconds with the antagonist silent or synchronous. Now, this could be called tonic because it's similar to a voluntary slow movement. The second pattern is where the EMG burst would be 50 to 125 milliseconds long, where the antagonist muscle is not exactly at the same time, usually reciprocal in nature. And this is what happens normally in a voluntary rapid movement, which is called a ballistic movement. So this could be called a ballistic pattern. And the third pattern is where the EMG burst is very brief, 25 to 50 milliseconds, where the antagonist is synchronous with the agonist muscle. And this is similar to different types of reflexes, such as the H reflex, and could be called a reflex pattern. These names, as I say, are not critical. The most important aspect is the pattern. And let me show you what those patterns look like in a little more detail. So these are actually normal voluntary movements, 2 different normal types of movements, and the top trace is a rapid or ballistic movement in which one sees what's called the triphasic pattern. This is a rapid elbow movement. The biceps is the agonist for a elbow flexion, and the triceps is the antagonist. And you see here a EMG burst in the biceps. Then there's a pause during which the triceps is active, and then the biceps is active again. So triphasic pattern. This is a 50 millisecond time bar, so these are just a little bit more than 50 milliseconds in their burst duration. So this is one type of pattern. A second type of pattern is this, what I call what is seen in a slow tonic movement, where, again, this is an elbow flexion. It's slow in this circumstance, and the EMG activity is a relatively long burst in the biceps muscle alone, although it could be co-contracting in nature. So these are 2 different patterns. Now, here are some more patterns, and these are actually physiological types of myoclonus, 2 different types. Let's first look at the one on the left. And you see here 4 muscles: biceps, triceps, finger flexors, and finger extensors. Here's a 100 millisecond time bar, and you can see a very brief EMG discharge, which is synchronous in all of these muscles, probably around 25 milliseconds or less. So this is what I refer to as the reflex pattern, a very brief synchronous discharge in all the muscles. In actual fact, there's parts of 3 myoclonic jerks here. There's the end of one at the very beginning, there's the one in the middle, and then there's one at the end. So 3 different myoclonic discharges, all of this reflex pattern. Now in part B is another myoclonic discharge, recorded at the same time base and with the same muscles and the same muscle amplitudes. And you can see that this whole EMG pattern here underlies one myoclonic jerk. This is very different in nature, and if you look at this pattern carefully, it looks like what I was referring to as the ballistic movement pattern. It has that sort of reciprocal nature, 50 milliseconds or 70 millisecond EMG bursts, and this is what you would see in a voluntary quit movement, although this is not a voluntary movement. This is a type of involuntary myoclonus. Now, you might say that what you see here on the left, this very brief discharge, should look different by eye from this very long discharge. And in fact, they can look very similar by eye. And the reason is because excitation-contraction coupling of muscle is relatively slow compared to the electrical events. So where this is easy to tell the difference by surface EMG, it might be difficult by eye. In any event, these are two different patterns that one can easily tell apart clinical neurophysiologically. Now here's a third myoclonus. This was seen in a patient that had DYT1 myoclonus, or DYT1 dystonia, but had also had myoclonus as part of the phenotype. You can see on the bottom here, this is a 200 millisecond time bar, and these EMG bursts are 200 milliseconds at the short side and go even much longer, 300, 400 milliseconds, underlying the myoclonus. So this is what I refer to as the tonic pattern. They are relatively long bursts of activity, and again, easily distinguishable from what we saw on the prior slide. So these are the reflex pattern, very short. This is sort of the intermediate reciprocal pattern that I call ballistic, and these are longer bursts that I call tonic. So with patients that have myoclonus, you can see potentially all three of these different patterns, which of course will have different types of etiologies. Now there's another type of pattern that one can see with myoclonus, and that's negative myoclonus as opposed to positive myoclonus. Negative myoclonus can also be called asterixis. And this particular type of recording here has an accelerometer which measures the movement at the wrist joint here, and these are extensors and flexors of the wrist. And you can see that the movements are occurring at the time of a synchronous pause in the EMG. So this is a negative phenomenon as opposed to the positive phenomena that I was showing you before. And this is something that one can also see, of course, when one looks at a patient that has myoclonus. But this has to be on the background of a voluntary activity to see it, since it is negative in its character. Let me show you another situation. This is a tick movement in a patient that had Tourette's syndrome. This is looking at a series of muscles, mostly in the right arm, but also, left arm, but also the left sternocleidomastoid muscle. And you can see that this pattern is a ballistic pattern. And many patients, of course, will say that they're making a voluntary quick movement in order to deal with the sensory pressure that is building up in them. And indeed, many of the movements do look like voluntary movements, such as what you see here. In patients that have chorea, there are random muscles affected at random times with movements characterized by random EMG burst durations. And in fact, in a patient with Huntington's disease, I did make this recording a number of years ago, and one can see almost anything. This is this brief pattern, here we have the ballistic pattern, and here we have a tonic pattern. So there's all sorts of things that come out in patients that have chorea. So looking at different types of involuntary movements then, patients that have myoclonus of an epileptic nature, as an epileptic fragment, will have this reflex pattern. Essential myoclonus has the ballistic pattern. Dystonic myoclonus has a tonic pattern. So again, myoclonus can have almost any of these. Tic can have ballistic or tonic, but never looks reflex. Dystonia would be almost entirely tonic. And chorea, dyskinesia, ballism, those can have mixtures of all sorts of things. So this is what the surface EMG would look like. So then the next neurophysiological test to add would be EEG to the EMG. What is the EEG doing while this EMG has occurred? And first thing, of course, would be just to look at the ongoing EEG to see what you can find. And this is a case of epileptic myoclonus. These are EMG recordings on the bottom and EEG on top. And this is relatively obvious. You have these very brief synchronous discharges that represent the myoclonus. And in many of the circumstances, there are epileptic spikes that one can recognize in the EEG. So this is clearly where the cortical activity is driving the myoclonus. Now, in some circumstances, this cortical activity is very low amplitude and difficult to actually see, even though it can be an epileptic cortical myoclonus. And in order to see that, one can use a technique called back averaging. And in that circumstance, one will average a series, hopefully the order of 50 types of events. And here's the EMG occurring. And if you use this as the trigger to average the EEG both before and after, this averaging in the backwards direction is called back averaging. And in that, you can see that there's a positive negative event that's occurring in the EEG that might not be apparent just on the raw EEG. And so this can be a spike then that is a very low amplitude, but can be appreciated with this additional method. Another technique then is to look at reflex responsivity, and in patients that have myoclonus, one can sometimes get sensory evoked myoclonus, and in those circumstances that's called a C reflex. C reflex, C stood for cortical, although not all C reflexes are actually cortical, but that's the way it was named originally. This is a very fast time sweep. This is only 200 milliseconds. A shock was given to the finger and myoclonus was produced. So here you have one myoclonic jerk that has a latency here of a little more, maybe about 50 milliseconds or 45 milliseconds. It looks long here, but it's actually short because the time sweep is so fast. So this is a reflex pattern, that very simple, quick discharge. You have one of them, and actually here's a second one. So you have two myoclonic discharges after this cutaneous stimulation. So these are C reflexes. Now, the next thing is then to look at all this simultaneously. You can look at the C reflex and the EEG at the same time. And this is a patient that has cortical reflex myoclonus. And if you're giving a somatosensory stimulus, you're looking at the EEG, you'll get an SEP. And so this is what the SEP looks like in this particular patient, and here's a topographic map of it on the right side. In terms of form, it looks perfectly okay, but there is a big abnormality here, which is noted by the size of this amplitude bar. This is 200 microvolts. So the amplitude of the SEP is 200 microvolts in amplitude. The normal upper limit is 7 microvolts. So this is a huge SEP. This is called the giant SEP, which is seen in cortical reflex myoclonus, representing a hyperexcitability of the sensory cortex, which then drives the motor cortex to produce this reflex response. You can see this particular topography at the time of the myoclonus, and a similar topography is seen in spontaneous jerks. So it's over the contralateral sensory motor cortex area, suggesting that that's the origin of where cortical reflex myoclonus comes from. Now, there's another type of back average that one can do on a longer time scale, and this is something that one can see with normal voluntary movements, and this is called the movement-related cortical potential, the MRCP. The actual potential itself prior to the movement is called the Bereitschaft potential. And it has two components, BP1 and BP2. In some older terminology from Shibasaki, this was called the negative slope. But BP1 and BP2 were good names. A slowly rising negativity and then a more rapid rising negativity over about a second and a half prior to the movement. So this is seen in normal voluntary movements, and it can be seen sometimes in other situations, such as psychogenic myoclonus. So in this circumstance, you have a slowly rising negativity, similar to what you see in a voluntary movement. Now, patients that have psychogenic myoclonus have this in an involuntary situation. So the Bereitschaft potential doesn't indicate voluntariness. What it indicates is activation of area 6, the supplementary motor area and the lateral premotor cortex. And one can see this in psychogenic myoclonus. In terms of looking at the Bereitschaft potential in a large number of individuals, in terms of control individuals, of course, that's what one would see in normal voluntary movement. In patients that have organic myoclonus, you would never see a Bereitschaft potential. What you see is that early spike-like potential that I was showing you. But in psychogenic cases, in 25 of 29, it was possible to see a Bereitschaft potential. Interestingly, in patients that have Tourette syndrome, only 6 of 14 showed any type of Bereitschaft potential. So it's much more common to see this in patients that have psychogenic condition. And this is what this would look like in a patient that is in a sort of normal subject. One sees a Bereitschaft potential before a voluntary movement. Patient with myoclonus of an organic nature, you won't see a Bereitschaft potential. In a patient with psychogenic disease, you can see a big Bereitschaft potential, as I showed you earlier. A patient with tic, it's not common to see a Bereitschaft potential, but can. And when you see it, it often consists only of BP2 and not BP1. Another manifestation in psychogenic myoclonus is the reflex latencies are very long. I showed you a case of organic myoclonus where the latency was about 50 milliseconds. In psychogenic myoclonus, what you see is this type of activity, which is at a voluntary reaction time latency. So those are the types of things that one would do. What did we see in this particular patient? The EMG bursts were 75 milliseconds long and asynchronous, similar to the ballistic pattern. The back average showed a Bereitschaft potential of 1.5 seconds in duration. And stimulus-induced myoclonus had a latency of 150 milliseconds and was highly variable in nature. So these points are all very clear, definitive evidence of psychogenic myoclonus in this particular situation. And this would be what we would call laboratory-supported psychogenic myoclonus. One would be very clear on the diagnosis in this circumstance and could go forward in terms of how to manage the patient as a patient that had a functional movement disorder in this situation. All right, I'm going to deal with a second patient now, one that has tremor. And this is another situation where clinical neurophysiology can be useful. In this situation is a 25-year-old man who had a complaint of recent onset of mild bilateral hand tremor. He has a strong family history of moderately severe essential tremor, and he's just gotten married, and he comes in, he's concerned not only about his own career, because tremor might be problematic for him in the future, but he's also concerned about what he might pass on to his children. So he wants to know, does he have the family disease as he's begun to have his recent onset of mild bilateral hand tremor? So the question is, this is something that probably would be almost impossible to tell by eye, but with clinical neurophysiology you can tell, and let me show you how you could do this. So I'm going to give a little bit of theoretical background first for the types of physiological testing that we do. The first important point is that a body part is a physical object, and a muscle and a joint are a physical object just like any other physical object. And every physical object has a resonant frequency. That is, if you give it energy, it will actually shake. And one considers then a physical object to have a mass and spring-like character, and if you hit it or knock it, then it will have a oscillation at the resonant frequency. And the resonant frequency is proportional to the square root of the stiffness divided by the inertia. So inertia characterizes the mass, the stiffness characterizes the spring-like properties. So if it is stiffer, the frequency will be higher, and if it weighs more, has a higher mass, the frequency will be lower. And this then characterizes the physical properties of that particular object, such as a muscle-joint combination. Now, body parts are obviously connected to the central nervous system by reflex-type arcs, and and there can be oscillations in these reflex arcs, and mechanical and reflex oscillations can be mutually entrained. So if they are close together in frequency, they can come together, and I will show you an example of how that can happen. The third situation is that you can have a central oscillator. So this is something outside of the reflex loop and mechanical properties, some sort of central oscillator that is producing rhythmic activity and driving the muscle. So in terms of possible sources of tremor, therefore, it can be purely mechanical. It can be what's called mechanical reflex, where you have a combination of these different mechanical properties and the peripheral loop. Or it can be from a central loop as well, so you can have peripheral loop just with the spinal cord or even longer loops. Or you can have a central oscillator. And central oscillators can be of two types. It can be some sort of neuronal oscillator where perhaps cellular properties of a neuron have it firing rhythmically, or it can be a property of a neuronal network, a sort of internal set of loops that can be active independent of the peripheral loop. This neuronal oscillator and neuronal network might actually operate together. It turns out, of course, that many networks that have oscillations have some neurons in them that have the capability of spontaneous activity themselves. All right, so how would we then study tremors in order to figure out which of these things is actually happening? And we use a combination of accelerometry, which can measure the acceleration of a body part, and EMG. So we look at these together, and we look at weighting of the limb, and the logic of weighting. Okay, someone I guess just joined. And the logic of weighting is what I mentioned before, that if you weight a body part, if it is a purely mechanical situation, the frequency will change and will become lower. And this is the sort of logic of what we'll be doing. So in terms of accelerometry, one can look at the raw data, where you can see the oscillations of a particular body part, let's say of the wrist. You can look at that and get a sense of what it looks like. You can do a frequency analysis of it. You can do a root mean square acceleration to get the approximate amplitude. So you can characterize by accelerometry what's going on. You can also look at the EMG. We often tend to look at antagonist pairs. So here's a tremor that's characterized by synchronous activity. Here's a tremor that's characterized by alternating activity. This is a case of essential tremor. And in this situation, you can either see synchronous or alternating activity. This is a case of Parkinson rest tremor. This is always alternating in nature. In general, almost anything can be alternating. So the EMG pattern is not that helpful unless you see synchronous activity, in which case it would direct you to the area of essential tremor. But let's now go to this more complex method, which actually gives us a clearer answer, where we're looking at the frequency analysis with both accelerometry and EMG simultaneously. And this is an example of a pure mechanical tremor. Here we have a recording of the EMG and the accelerometer. This is called tremor here. And what you see is that you have a tremor peak, which is somewhere between 6 and 8 hertz, but the EMG is relatively flat, so the EMG is not participating in it. You weight the limb, and the tremor frequency now goes down to be somewhere between 4 and 6. So this is a purely mechanical tremor. The EMG is not participating, and the tremor frequency goes down with the weighting. Now, this second one, which is called enhanced, and I'll explain why in a minute, is a mechanical reflex tremor, where you have a short loop of reflex participating with the mechanical situation. And here, when you do the recording without a weight, you have tremor and EMG both at the same frequency of 8 hertz, and then you weight it, and the EMG and the tremor together go from 8 to 6. So these are mutually entrained together, but it's the EMG and the oscillation together behaving as a mechanical system, even though the reflex is involved as well as the mechanical. And then this is the third situation, which is a central oscillation, here called 8 to 12, and I'll explain that in a moment. And here you have tremor at about 8 hertz, and you have an EMG, which is a little broad, but you can see a peak here around 10 to 12 hertz. You weight this, and you wind up with two different tremors, one which goes down from 8 to about 5, and another that really jumps up to join the EMG here at around 10 to 12 hertz. So this is a mechanical peak. It goes down with with the weighting, but you also have a peak here that is fixed in frequency and goes along with the EMG, and this is a central oscillation. Now, it turns out that all three of these, and here this is all three things I'm showing, can be seen in normal individuals. This is a purely mechanical oscillation, which would be physiological tremor, which you would see in everybody all the time. This is enhanced physiological tremor, which is a mechanical reflex situation where the oscillation is increased because of the involvement of the peripheral loop. And here you have a central oscillation. In some normal individuals, but not all, you have an 8 to 12 central peak that also contributes to the physiological tremor. In people that have essential tremor, you have a very strong central component. The EMG and the tremor are going very strongly here. You weight the situation, and it basically remains the same, although you can split off, in some circumstances, a smaller mechanical component. You always potentially have a mechanical component, of course, because a body part is a physical object, and you can't escape the fact that it has a resonant frequency. So then when you do these sort of tests, you can divide to mechanical reflex, or a central oscillator, and you have physiological tremor, exaggerated physiological tremor, and then a variety of central oscillators. Essential tremor, Parkinson rest tremor, psychogenic tremor are central in nature. Let me just say a few words about psychogenic tremor, because it does come up from time to time, and there are physiological features that one can see. Let me just show you some of those in the next slides. One of the aspects of psychogenic tremor is a highly variable frequency over time. These are frequency plots over time, and you can see that it's highly variable here compared to Parkinson's and essential tremor. Another point which is not well recognized is that in Parkinson's disease and essential tremor, while the tremor frequency is similar in the two limbs, the right arm and the left arm, it's actually always not exactly the same. So here's a case of Parkinson's disease, 4 hertz in one and 3 hertz in the other. Here's another one. Here's a case of essential tremor, relatively close, but not exactly the same. And in this paper, the authors claimed that this was a rare case of Parkinson's disease. You can see that it's exactly the same through all this time period. And I would say that the authors are confused. This is almost certainly a psychogenic tremor. The oscillators in Parkinson's disease basically are independent, even in body parts on the same side. So this is almost impossible to be Parkinson's disease, and is what you see in patients that have psychogenic disease. Another feature is to look at what's called entrainment, where you ask an individual to tap with one limb while you're recording the involuntary tremor on the other limb. Now, in an organic tremor, here you have a organic tremor going here, tapping with one hand. These are at slightly different frequencies. The tapping frequency doesn't entrain the actual tremor. In a patient with a psychogenic problem, here you have the tremor, which is entrained to the tapping frequency. So they turn out to be exactly the same in frequency and actually coherent in phase, so that you can measure the coherence as well as to see that the frequencies are exactly the same. Another way of looking at psychogenic tremor is to do the so-called ballistic movement test. It's very similar to entrainment, but it's just a single quick movement. So in someone who is making a voluntary oscillatory movement of one hand, if you ask them to make a quick movement of the other hand, there will be a short pause. This is also seen in psychogenic tremor, but in patients that have a central oscillator, such as in Parkinson's disease or essential tremor, there's no stopping of the oscillation. So what about this particular patient then? What did we see in this case? This person had a 6 hertz tremor at the wrist, seen with both accelerometry and with EMG. Weighting with 1 pound led to a change of 5 hertz, and 2 pounds went down to 4 hertz. Now, just to point out something I perhaps didn't say before, we generally use more than one weight when we're doing this test. It is helpful to see in a situation like this where one is weighting that it's a progressive decrease, so that this is what one would see with a mechanical situation. The heavier it is, the slower the frequency. So at that point, one has really come up with the diagnosis. This would be an exaggerated physiological tremor, and there's no need to do entrainment studies or anything else. The issue of whether this could be psychogenic or not is not really in the cards. So one wouldn't have to do entrainment studies, but if that was still on your list, that would be the next thing that one might do in order to try to help with the diagnosis. But I think here we have an exaggerated physiological tremor that we are dealing with. Now, of course, once one makes that diagnosis, one would want to go a bit further. Why is it exaggerated in this particular individual? Now, I must say that in some of the people that we've seen in this circumstance are very heavy coffee drinkers. I'm surprised how much coffee some people can drink, and this can be a reason. And of course, anxiety is another possible explanation for this in some individuals. But further investigation in this particular individual showed that he had a mild thyrotoxicosis as the explanation for his disorder in this circumstance. So we were able to help him along in this situation. He, at least at this point, doesn't have the family disease, but we found something that's also medically relevant for him and is certainly helpful. So then, in terms of conclusions, I hope that I've shown you here by these two examples that movement disorders can be even though some of them can be diagnosed on clinical grounds, there are often difficult cases where it isn't clear. The clinical neurophysiology can be helpful, and I think myoclonus and tremor are probably the two best examples of this. We can also quantify these things. One can measure the magnitude, particularly of tremor, so you can get a record of how severe it is on one occasion versus another. And of course, and what I do most of my time for a living is to do research with these techniques, hoping to understand these different movement disorders better. So in the future, one can develop a lot more rational and better therapies for these patients. So I think that's the end. This is a picture of the front of the NIH Clinical Center where I work, and I'd be happy to deal with any questions that you have about what I've just been telling you. So thank you. Okay, good. So I guess what I'll do is to turn off my slides. Is that right? Is that what I should do? So I can see you? Now you can see my daughter and my granddaughter.
Okay, thank you very much, Mark Hallet, for this excellent talk. Maybe we start in Lausanne. Has anyone a question? Yeah, you have to come down here, the question. Look at the camera.
Here.
Yeah.
Okay, so my question is, when you spoke about a tremor with frequency 8 to 12, does it have anything to do with alpha rhythm, and what is the relation if there is some? Thank you.
Anything to do with what? I'm sorry.
With alpha rhythm of EEG.
Okay, so, right. So, there is this normal 8 to 12 hertz tremor that you can see in many normal individuals. It's probably the order of 15% or so of normal individuals have this as a part of their physiological tremor. The actual nature of that 8 to 12 hertz tremor has never been clear. Where that oscillation comes from is not known. It isn't clearly related to the EEG in any way that anyone has ever identified, and the source of it is really unknown. I must say, up until a couple of years ago, I had the guess that the 8 to 12 oscillator, whatever it was what became abnormal when you developed essential tremor. Part of the logic of that was a rather dumb logic, to say that we don't know the origin of either one, so maybe they're the same. But actually, we have now seen one patient here that had both the 8 to 12 hertz tremor and a tremor, I guess it was about 6 hertz of his essential tremor, and it had it in the same arm simultaneously. So they clearly are two different oscillators, but the origin of that is unknown. Occasionally, it will give some difficulty in making a decision as to whether someone has a physiological tremor or essential tremor, and that's one of the that is a situation that can prove to be a little bit difficult.
Okay. Thank you very much, Mark. I might ask Ara to guide now the discussion, because I don't see who is connected with us and whether somebody has a question.
Well, we have one question from Ara, actually. Sometimes it is very difficult to differentiate between essential tremor and dystonic tremor. Is there any specific pattern for dystonic tremor?
Right. So that's a very good question, and we are actually studying that right now in our laboratory. I'll be able to answer that question for you, hopefully, in about 6 months in a little bit more detail. The first point to say is that I am sure that there are a number of situations of tremor in the setting of dystonia where it is identical to essential tremor. We know this because there are certain families where essential tremor and focal dystonia run together. Some individuals seem to have tremor, some have focal dystonia, and some have both. So I think in those families, I would guess that the tremor that they have is in fact identical. Now, there are other circumstances, and I suppose it's most common in the neck, where you have a little bit of posturing of the neck and also tremor of the neck. Those tremors tend to be a little bit irregular, and I think that that's one of the facets that people say separates it from essential tremor. But it really is at the present time, it still is quite difficult to make a separation. It is a central oscillator and has a number of similar characteristics. Now, there is one physiological test that has been claimed to separate out essential tremor and dystonic tremor, It's only been done in one study, and again, we are trying to reproduce this now as well. And that is looking at temporal discrimination thresholds. This is a sensory test where one looks at the shortest interval where one can tell that there are two stimuli rather than one. And in people that have dystonia, it's been known for a long time that there's a prolonged interval, so temporal discrimination threshold is higher. There's one report that in pure essential tremor, temporal discrimination is normal. So that while we see in dystonia a sensory abnormality, this is not seen in pure essential tremor, and that may be a way of separating them. That isn't looking at the characteristics of the tremor itself, but it is a physiological technique that may be able to be helpful in some circumstances. Again, in about 6 months or so, I'll be able to tell you whether there are other physiological characteristics of the tremor that will be different between the two, but at the moment, we don't know the answer to that further.
Ich muss jetzt einfach das Mikro aktivieren und dich melden.
St. Gallen, man hört euch schon.
Is there another question there? This is a difficult matter, flipping between all the different sites.
This is Sebastian Schiegelmann from St. Gallen speaking. Thank you for your talk. This might be a difficult or maybe even impossible question to answer, but I still think of when you, especially with psychogenic movement disorders, when you talk about the sensitivity and specificity of testing, the question is, what is the gold standard you compare it to? And you've mentioned on some of your slides, well, in some of these patients diagnosed with this and that, this sign was positive. So the question comes up, what in your feeling is the gold standard?
Mm-hmm. Right. So I suppose as far as the field is concerned, the gold standard of making a diagnosis that is completely definitive is the fact that the patient will in fact improve after psychotherapy or physical therapy. That if you can demonstrate that it will go away completely in that circumstance, then everyone would agree that it was in fact psychogenic, that there's no other types of intervention that one has done. Now, I think that a number of these laboratory tests that I have been showing you are also now pretty much considered to be very close to the gold standard. What they show is a pattern of activity that is similar to what you see in voluntary movements. And those types of patterns are not seen in any type of organic disorder. So I think that people are beginning to get the sense that if you see that you can be very sure that that's the case. And I would say that that would be the situation, for example, in that patient case 1 that I showed, where there was the Bereitschaft potential that was present there, and reflex latencies that were seen of the myoclonus that was at voluntary latencies. That's just not seen in any other situation, and we know that psychogenic conditions utilize voluntary output mechanisms. It doesn't mean that it's voluntary, it just means that this is something that is used by patients that have psychogenic conditions. And so I think that, therefore, the term that I used before was laboratory supported. So one would say this is a laboratory supported diagnosis, and it's pretty close to the gold standard. But the gold standard is, in fact, getting better after psychotherapy or physical therapy.
Thank you.
Okay, thank you very much. Now we are switching to Geneva and ask Geneva to ask their questions. Geneva, we can hear you.
I have a question. Do you see me? Or?
Yes, I could hear you. Yeah.
Okay, thank you. That was a great presentation, Mark. You showed this little, let's say, hint of localization of the EEG, because that was one of the slides, the EEG, EMG. What do you think would be the contribution to go with further higher electrode counts, since that's our hobby here? And do you think there's some future also in terms of treatment to get to know the sources of essential tremor or other things which sometimes are difficult to treat medically? What's the latest on that?
Well, in terms of identifying the localization for myoclonus, that of course I think is often very valuable in these individuals. There are some cases, of course, of cortical myoclonus where there is a focal lesion that is there, and if one has EEG localization, perhaps as the first step, one could be drawn to a possible focal lesion that would have, of course, therapeutic implications. Also, I didn't have time to talk about possible other origins of myoclonus, but it is possible to have brainstem origin that can look superficially the same. And I think that there is a little bit difference in terms of possible etiologies and therapies for both brainstem and cortical origin. So I think in that sense it is nice to know. In relation to identifying the source of tremors, EEG has not been that useful yet in this circumstance. Now, it is the case that the motor cortex is involved with almost all tremors. In fact, I can go further. The sort of loop between the cortex, the cerebellum, the thalamus, and the cortex, the cortico-cerebello-thalamo-cortical loop, is involved with almost every tremor as its output. Now, the question is often not where the tremor is coming from, because it's coming from this central loop. The question is what's sort of triggering that loop into activity. So the EEG will, in fact, from the motor cortex, will be coherent with the limb EMG. One can actually demonstrate that in a number of circumstances. But that doesn't mean that the motor cortex is, in fact, the single site generator in this particular situation. So I think while the EEG can be used, it's a matter of research in this situation. I don't think it really helps you that much diagnostically at this point.
Diagnostically, but for treatment, TMS or neuromodulation, to put that in certain frequencies or certain sites, or also MEG. I think you guys do more MEG. There's something which would help to identify better treatments in that sense, I would.
Well, yeah. So we do use MEG. We use EEG depending upon the different situation. Again, our goals have been, including our work that we're doing now, trying to separate essential tremor and dystonic tremor. We're using MEG methods to see if we can help identify sources for all of this activity. You also mentioned TMS, and it's possible that there will be TMS techniques or DCS, DC current techniques that will suppress tremor, either over the motor cortex or the cerebellum. And I think to a certain extent, the logic of those is what I mentioned before, that the output loop in almost all tremors seems to involve that cortical cerebellar system. So one can influence tremors in those locations. And it might be useful therapeutically in some circumstances, but exactly where the tremors are coming from, we still don't know exactly.
Okay, thank you.
Okay, thank you. The next question will come from Lucerne, from
Anybody question?
Bauhalters Group. Are there any? If okay.
Can you hear me?
Yeah, we can hear you very well.
I have a very simple question. Is there a commercially available system to do back averaging, or is this just something you have in scientific laboratories?
Stefan, I'm getting a lot of echoes with that, so I mean, I can see you very clearly, but I can't understand what you were saying just then.
Sorry. This is a back averaging method, which is very interesting in diagnosis, to diagnose psychogenic movement disorders. Are these systems somehow commercially available, or
Right. Back averaging, yes. Back averaging is a very nice technique, as you saw. The question is it in fact commercially available? It is actually something that is available on at least some EMG machines that I've seen, and I have tried to use those. It's not that great on those machines, I must say, and for almost all my career, we have been using homemade apparatus for this. So I'm afraid that the companies are not doing a good job in providing machinery that is very helpful for it. And it's been a while since I've tried this, but there have been a couple of EMG machines that I've seen that have allowed 4-channel back averaging, and you really don't need more than that. I mean, one can possibly get along with that, and I have been successful using them, but they aren't really designed well for that purpose. So you are right that this is something that if a physiology lab wants to do, it's really best to sort of get set up on your own.
So you have to send a fellow in your laboratory for that.
Right. Yes, that's exactly right.
Thank you very much.
Okay, thank you. Are there any questions from Chuk?
Thank you for this wonderful lecture. I do have a small question on cortical myoclonus. In the differential diagnosis for intoxication versus epileptic myoclonus of cortical origin, do you have any suggestions how to assess those problems?
You mean you're now talking about the etiology of it? Is that right?
I just have a patient. We had a patient where he came with a diagnostic of epilepsy and turned out to be a lithium intoxication. Do you think EEG or back averaging could help in this situation?
Yeah. So I suppose that's a very good question in terms of developing a sort of general point, and that is that the physiology takes you only so far. It can identify the physiological nature of the myoclonus in such a situation, but doesn't necessarily tell you about the etiology of it. So that if you have lithium intoxication, as you're just saying, or if you have some sort of intrinsic epileptic abnormality or sort of genetic abnormality, it could potentially look exactly the same. So I don't think that there's there that really can tell you that it is the etiology. It is the physiology that we're seeing. Now, of course, there are other possible things that you could see. Someone that has lithium intoxication is also going to have an exaggerated physiological tremor. This is something actually that we have looked at here, looked at people that have had high doses of lithium, and they almost all have exaggerated physiological tremor. So if you see an exaggerated physiological tremor as well as the myoclonus, it could perhaps give you a hint that there could be something more than just sort of genetic cause of cortical myoclonus.
Okay, thank you.